A very good afternoon and a warm welcome to the day 3 of our World Liver Day Conclave. Hope you are making the most of the 3-day clinical discourse. Now, this session is planned as an expert talk on NFLD management. Non-alcoholic fatty liver disease, the most prevalent chronic liver disease, is characterized by extremely complex pathogenetic mechanisms and multifactorial etiologies. The major pathophysiological mechanisms leading to NFLD include oxidative stress, impaired mitochondrial metabolism, inflammation, gut microbiota, etc. So, to gain more insights on NFLD, we have with us Dr. Pallavi Garg. Welcome, ma'am. She's a senior consultant gastroenterology at Max Super Specialty Hospital and also the director of Cure Clinic in New Delhi. She has over 20 years of clinical experience and is a member of the Indian Society of Gastroenterology and the Indian National Association of Study for the Liver. She was awarded for her paper presentation in 2007 by the ACPM Research Society, Dhule. Dr. Garg has several national and international scientific publications to her credit, and her special interest includes in hepatology, liver transplant endoscopy, and inflammatory bowel syndrome. So it's a pleasure to have you with us here, ma'am. Please go ahead.
Good afternoon, everyone. Thank you, Darshika. First of all, I would like to thank Doplexus for having me here. And the task assigned to me today is the management of non-alcoholic fatty liver disease. So let me first define what is non-alcoholic fatty liver disease. So it is nothing but presence of excess fat in the liver, accumulation of excess fat in the liver, which is seen either by imaging or a histology. What is non-alcoholic fatty liver disease is the presence of alcoholic steatosis without any evidence of hepatocellular injury in the form of ballooning of the hepatocytes. Whereas non-alcoholic steatohepatitis or NASH means there is hepatic steatosis. Along with that, there is inflammation and some hepatocyte injury along with or without fibrosis. So the spectrum of this disease, non-alcoholic fatty liver disease, is from simple steatosis, simple non-alcoholic fatty liver disease, to NASH, that is steatohepatitis, which includes inflammation, hepatocyte injury with or without fibrosis, and cirrhosis of liver, where there is a frank fibrosis of the liver. And at few instances, we also see hepatocellular carcinoma with or without cirrhosis of liver. How prevalent is this NASH? So I would say this is no short of an epidemic. This is also a burning problem not only in the Western world but also in our part of the world. So now Nafld has become the most common chronic liver condition in the Western population. Of course, we all know that it is fueled mainly by obesity and type 2 diabetes. Globally, the prevalence of Nafld is approximately 25%, and so it is in our country as well. It is estimated the prevalence of Nafld is around 25%, whereas NASH prevalence is around 1.5 to 6.45%. It is more prevalent in patients who are obese or in patients having type 2 diabetes. And it is expected that NASH would probably be the leading cause of liver transplantation in US between 20 to 25. So as we have already discussed, it is more prevalent in patients who are obese. So a large chunk of population who is already obese, out of which around 50 to 90% have Nafld, of which around 15 to 50, that means almost half of it, have NASH. So the prevalence is more in patients who are obese. Similarly, in patients who are diabetic, around 60 to 80, meaning almost two-thirds of them have got Nafld, of which around 20 to 80% also have NASH. Coming to the pathogenesis of NASH. So this is mainly fat in the liver, which is seen either by imaging, and this fat, this excess adipocyte collection there can damage the liver, can lead to some inflammation along with or without fibrosis. So, and diabetes is a major association. Basically, Nafld is nothing but it is one more manifestation of metabolic syndrome. along with diabetes, along with hypertension, dyslipidemia, PCOS, NAFLD is also a part of metabolic syndrome. So basically, it is nothing but adipose overload, which leads to insulin resistance. So, from stressed adipocytes to hepatic lipotoxicity to inflammation and to cirrhosis. So, this pathway, this journey is covered by first there is excess delivery of dietary fat, there is excess production of fat from the sugars, which leads to insulin resistance in the adipose tissue, which leads to more lipolysis, more adipocytokines, and less adiponectin. If there is increase in insulin, there is increase in glucose, which leads to increased fatty acid supply, which leads to increased lipotoxic fatty acid derived metabolites. And then there is steatohepatitis, there is mitochondrial dysfunction, endoplasmic reticulum stress, which leads to activation of stellate cells. There is steatohepatitis or fibrosis, and which leads to cirrhosis of liver. I have also included in this slide few places where we can have some intervention. Like first, from where there is excess delivery of fat, we can have some lifestyle modification. Then at the various levels, there are certain agonists and receptors which we can use for the management, or we can have some intervention to correct the underlying pathogenesis. Type 2 diabetes is a major risk factor for advanced fibrosis of the liver. So, a meta analysis was done with more than 3,000 patients, and it was seen that in the fibro test, then Nafl fibrosis score, or with the help of transient elastography, the patients with diabetes had a more advanced degree of fibrosis compared to the general population. So, when there is fat supply exceeds the adipose storage capacity, there is insulin resistance, which leads to NAFLD. Along with that, it also leads to dyslipidemia, hyperuricemia, hypertension, type 2 diabetes, macrovascular diseases, which includes cardiovascular disorders, and hyperglycemia. So, all together makes the metabolic syndrome. So, what are the various risk factors and how do we do a screening for NAFLD? So, the guidelines are, as per the American Society, it says that in patients with type 2 diabetes, suspect NAFLD and NASH and determine the patient's risk for advanced fibrosis. So, if the patient has got increasing number of metabolic diseases, for example, somebody has got diabetes, along with that, the patient has also got hypothyroidism, hypertension, dyslipidemia. So the risk of having a liver disease increases. So try to screen such patients. Whereas the EASL guideline says that anybody who is at higher risk, for example, age is more than 50, patient has got diabetes and metabolic syndrome, so we should do a NASH and advanced fibrosis screening is recommended in such patients. What is the presentation of NAFLD? So generally, most of the patients, at least in the initial part of the disease, are asymptomatic. Probably this is the reason why the number of NAFLD and NASH patients is increasing so rapidly, because the disease is unfortunately picked up at a very later stage or very advanced stage of the disease. So usually it is asymptomatic and it is just discovered by chance, maybe during some executive health checkups or in patients who visit to their endocrinologist or a diabetologist, or in some hypertension clinics, or patients with dyslipidemia while doing their routine evaluation find that their LFTs are also deranged and they visit the physician or the hepatologist. If at all the patient is symptomatic, they generally present with fatigue, right upper quadrant discomfort or heaviness, and incidentally or just a routine evaluation or a LFT done for some other reason picks up abnormal LFTs, or an ultrasound may be done as a routine evaluation or again for something else picks up a bright liver, or incidentally, when examined by a physician, they have hepatomegaly. So, what are the first steps in patients with suspected Nafl? First of all, what are the various risk factors? So, patients with metabolic syndrome and high prevalence group like age more than 50, or patients with type 2 diabetes, or BMI more than 25, patients with PCOS, patients with obstructive sleep apnea, patients with dyslipidemia, or first degree relatives of NAFL cirrhosis, or patients with hepatocellular carcinoma. These are the high risk population. Somebody who does not give any history of any pre-existing liver disease and who takes alcohol in moderation, but is suspected to have some liver disease, we should always think of NAFLD. So in the tests, the liver biochemistry shows some derangement. We have to exclude hepatitis B and C serology, exclude all the autoimmune parameters. Patient is negative for celiac serology. The immunoglobulins, ferritin, ceruloplasmin is normal, and the ultrasound says that there is increased echogenicity, which is suggestive of steatosis. So liver enzymes are inadequate in assessing NAFLD or NASH. So it is not that ALT is neither indicative nor predictive of the fibrosis stage. So normal ALT does not preclude NASH or a progressive disease. So if the doctor is suspecting that a patient with a high risk, somebody with a BMI of 30 with underlying diabetes, but the ALT report comes normal, does not excludes that he does not have NAFLD. He may be having NAFLD, or elevated ALT cannot predict NASH or fibrosis. That means it does not indicate that somebody with an ALT of 40 and somebody with an ALT of 80. So the one with the ALT of 80 has a severe degree of NASH or has a higher or an advanced stage of the disease. So it is ALT or AST are not sensitive for NAFLD or NASH, but abnormal ALT can warrant the workup for NAFLD. Any physician, if the patient presents with abnormal ALT, the probability of NAFLD should also come to the mind of the treating physician. But it is not sensitive to confirm or to rule out or to characterize the severity of the disease. So, how can we identify NAFLD on ultrasound? Ultrasound can either say it is a normal liver or it can pick up a fatty liver. However, in ultrasound, it is difficult to differentiate between steatosis, steatohepatitis, or fibrosis or early cirrhosis. So, if ultrasound cannot give us the complete information, ultrasound cannot grade the various stages of the disease, then there are various other imaging tests which can help us with this. So, at present, fibroscan, which is nothing but a vibration controlled transient elastography, is considered to be the standard of care. It is most reliable, especially in ruling out the advanced hepatic fibrosis. There's something called MR elastography or MR spectroscopy. It is most diagnostic, most accurate method of imaging. However, it requires radiological assistance as well. And cost also is an important factor. 2D shear wave elastography, again, it requires the radiological reference but can be the point of care with minimal training. So these imaging tests can measure the liver stiffness, which is an indirect measure of the hepatic fibrosis and not the hepatic content, hepatic fat content. So far, the gold standard or the 100% the diagnostic test to assess liver fibrosis or to diagnose somebody with NASH still is liver biopsy. However, it has got multiple limitations. First of all, it is invasive, it is painful for the patient, it is expensive, it requires trained medical personnel, it has got some morbidity and mortality as well. There can be a sampling variability from which area of the liver exactly the tissue has been biopsied. Expertise is required and it is impractical for a mass screening. So what are the non-invasive tests we generally use? So the laboratory tests include simple FIB score scoring or the Nafl fibrosis score. Also very basic, simple AST platelet ratio can be used. On the imaging side, we have transient elastography, 2D shear wave elastography, and MRI PDFF. So then there are so many tests and so many scoring systems available. How do we proceed? How do we plan and how do we manage a patient whom we are suspecting to have NAFLD? So first we have to categorize the patient into a low risk, intermediate risk, and a high risk patient. Anybody with a low risk who comes to us with a suspicion of NAFLD, we either do the serum test or the imaging. In serum test, we can do a FIB-4 score, NSF, or ELF score. In imaging, we can go for either elastography or we can go for MR elastography. So if in the low risk, if the patient is ruled out to have NAFLD, story ends. If the patient is still on a high suspicion of NAFLD, if we have done a serum test, we go ahead with the imaging modality and we confirm by the imaging. And in high risk, again, we confirm with imaging if imaging was not done previously. Coming to the management of NAFLD or Nash. So first and most important is weight loss in a patient who is overweight. So what are the various approaches to weight loss and what is its effect on the liver? Most important is energy restriction, which includes caloric restriction up to 500 to 1000 calories per day, leading to 7 to 10% of the weight loss. Most important is to have a long-term maintenance also, which is most difficult. The patient has to cut down on the fructose intake, alcohol intake if it is excessive, and macronutrient composition has to be closely monitored. Patient should increase the physical activity in the form of 150 to 200 minutes per week of moderate intensity, which can be divided over 3 to 5 sessions. There should be resistance training, musculoskeletal fitness to improve the metabolic factors. So even in somebody with a lean NASH, wherein the patient is not overweight, we can promote and we should encourage physical activity. So, if the patient has already gone ahead with the physical lifestyle modification in the form of some dietary change, weight loss, exercise interventions, and calorie restriction, everything has been done. But unfortunately, if there's no response, we can think of something called bariatric surgery, which reduces the liver fat, improves the histologic lesions of NASH, including the fibrosis. The decision to go ahead for such procedures, which can be either endoscopic bariatric procedures or bariatric surgery, has to be individualized based upon patient's needs. However, the unfortunate part is that studies showed that weight loss techniques were conducted in a population with or without NAFL, and only 48% of NAFL patients were able to achieve their target weight loss. So only 48% of the patients were able to achieve the target weight loss of at least 5%. Now coming to the pharmacotherapy. If the weight loss exercise, of course, which is most important, but most difficult to achieve. Then going on to the pharmacotherapy, we have the drug which is most commonly recommended by most of the societies is vitamin E. So in a non-diabetic patient with a biopsy-proven NASH, a dose of 800 international units per day has been recommended by American Association, by the European Association for the Study of Liver Disease. Whereas pioglitazone is recommended in patients with or without type 2 diabetes and biopsy-proven NASH. So coming to the safety and tolerability of vitamin E and pioglitazone. So in vitamin E, Generally, it is found to be safe. There's a very, very small risk of hemorrhagic stroke or conflicting reports on prostate carcinoma. So, the American Association for the Study of Liver Disease recommends vitamin E at a dose of 400 international units twice a day for non-diabetic NASH. However, now there is data on diabetic NASH as well as cirrhotic NASH. A dosage of 400 international units twice a day for up to 2 years or maybe longer can be used. And it has shown that to an extent, it decreases the decompensation or it decreases the advancement of the liver disease. Various pharmacotherapeutic agents and the points where the mechanism of action of these drugs comes. So we have PPAR, gamma, PPAR, dual PPAR also, that is alpha and gamma, pioglitazone and saroglitazar. Then we have GLP-1 agonists like liraglutide, semaglutide, SL, SGL2, and we have DPP4 also. The new drug which is coming is FXR, that is the OCA. So coming to individual, so multiple drugs are there, some oral and some injectables. In the injectables, the one which is used so far is semaglutide. So what is the target for pioglitazone? It is the PPAR. Here, it mainly acts on the necroinflammation. So, RCT was done in NASH patients with type 2 diabetes and in the pre-diabetics. So, in 18 for a duration of 18 months, patients were either subjected to placebo or pioglitazone in the dose of 45 milligrams per day. And the primary outcome was more than 2-point reduction in the NAS score without worsening of fibrosis. However, there were some side effects noted with pioglitazone, that is, there is a weight gain over a period of 1 to 2 years of approximately 2.5 to 4 kgs. There can be redistribution of fat, which leads to increased adipose tissue triglyceride synthesis. And there is a small controversial risk of bladder cancer. ASLD recommends pioglitazone for diabetic and non-diabetic NASH patients. Combination with vitamin E can be better, and weight gain may be counterintuitive to its routine use by the hepatologist. Next is saroglitazar, which is the new star. This is the only drug which is approved by DCGI. It can be very confidently used in patients with Nafld and other comorbidities, and in patients who are non-cirrhotic but NASH with advanced degree of fibrosis, patients with diabetes and dyslipidemia, patients with diabetes, dyslipidemia not controlled by statin. So it's a dual PPAR alpha gamma agonist. The action is to on the increased fatty acid oxidation, and the PPAR gamma works on the improved insulin sensitivity, increased glucose homeostasis, and to decrease the inflammation. So various studies were done which showed that with saroglitazar 4 milligrams per day, there is improvement in the fibrosis score, there is decreased ballooning, and there is Nash resolution in a significant number of patients. What is Nash resolution? Resolution of steatohepatitis on overall histopathological bleeding and with no worsening of liver fibrosis. Or fibrosis improvement is when there is improvement of more than one fibrosis and there is no worsening of steatohepatitis. Because of the slow progression of NASH, the FDA recommends liver histological improvement as endpoint reasonably likely to predict the clinical benefit and to support the accelerated approval. Coming to semaglutide. So now this is GLP-1 analog. Here, it is known to reduce the liver steatosis, but has got no action on liver stiffness. The new star, the rising star is FXR or the obeticholic acid. So, phase 3 regenerate trial was done wherein 2 2,400 patients were subjected to either placebo, 10 milligrams of obeticholic acid, or 25 mg of obeticholic acid for a period of 18 months. And the primary endpoint was either a fibrosis improvement of more than one stage without any worsening of Nash, or Nash resolution without any worsening of fibrosis. So in this trial, it was seen that there was significant fibrosis improvement of more than one stage in patients who had received a dose of more than 25 milligrams. Similarly, the fibrosis improvement of more than two stages without any worsening of NASH was seen in patients with more than 25 milligrams. However, this drug again comes with few adverse effects. It has got the adverse effects include pruritus, which is generally mild in most of the patients, but a few case reports of severe pruritus have been reported. It leads to dyslipidemia, mainly increase in the LDL levels. And there has been a black box warning that says that there can be hepatic decompensation, hepatic failure, especially when it is used in advanced stage of cirrhosis, that is CTP score of more than class B or C, the risk of decompensation and liver failure increases. So in such patients, it has to be used at a lower dose. So it is the only drug which has shown to improve the fibrosis in case of NASH. But despite this, it has not received any approval from FDA or DGCI so far. Data amongst the patient with cirrhosis, especially advanced cirrhosis, is still lacking. Maybe the adverse effect profile, maybe the rate limiting step for the use of this drug more uh, frequently. So just to summarize the whole thing, patients with Nafld or Nash management, first and most important is weight loss. Weight loss includes the lifestyle modification, diet and physical activity, use of anti-hypoglycemic agents if the patient is diabetic, or to promote the insulin sensitivity, have a good glycemic control, control of other metabolic diseases like hypertension, dyslipidemia, hypothyroidism. Consideration is given to bariatric procedures, which includes either surgery or endoscopic procedure, use of statins, either for dyslipidemia or for the reduction of portal hypertension. Use of metformin is again contradictory, and liver-directed treatment especially focuses on vitamin E, pioglitazone, and saroglitazar so far. So to summarize my talk, I would say lifestyle modification is the only durable therapy, but very difficult to follow and endure. Many targets are available now for the pharmacological interventions in NAFLD. Thank you.
Thank you so much, ma'am. It was a pleasure listening to you. It was a really good presentation. Given the short notice, I think you've done a fairly good job. Yeah. I have a couple of questions for you, so we'll take those. So my first question is, in terms of lifestyle modifications, you did mention. So what are the measures in cases where a plateau occurs for weight loss?
So as we have already discussed, first coming to what are the various lifestyle modifications. Patient has to have a proper diet management. Patient should cut down the calorie intake to maybe 500 to 1,000 calories per day. Target weight loss of 7 to 10% of the body weight should be achieved. And if a plateau has achieved, then we have to think of other therapies, like either we have to intervene with the help of pharmacotherapy, the drugs as we have already discussed, or then there are some procedures, some bariatric procedures, including endoscopic procedures or surgical procedures. So patients, so it is basically based, it should be personalized, it should be patient based. So taking into consideration the entire profile of the patient, associated comorbidities of the patient.
My second question is, what series of screening for NAFLD would you suggest physicians to follow, who are usually the first point of contact of patients?
Right, absolutely, a very good question. So somebody who comes with an ultrasound report which says somebody who comes with a deranged LFT, and really physicians are the first point of contact for such patients. So it is very important for us to have an awareness amongst the physicians and to set a proper protocol how this patient should be investigated. So somebody with a low risk, as we've already discussed, we can even go for some serum test, which includes simple liver biochemistry or the FIP score. And if the patient is low score, if the score is normal, great. If it is abnormal, we can go on to the imaging. Imaging includes again an ultrasound, which can just pick up fatty liver disease or a fibroscan or an MR elastography. So these are the various tests by which, of course, the gold standard is liver biopsy to confirm NASH. But however, as we have already discussed, there are a lot of laws with that. So I suggest if really there's a doubt, only then go for liver biopsy. Otherwise, we can diagnose NAFLD or NASH easily on the basis of biochemistry and imaging.
These were the questions I had for you. Thank you so much for answering all these queries. And it was great to have you with us here. Looking forward to more such
Thanks so much.
sessions with you.
Thank you.
Dear audience, stay tuned for our next and the last program for World Liver Day Conclave 2022. Today's evening at 6 p.m. with Dr. Sudhindan, who shall discuss a surgical demonstration of minimally invasive liver resection techniques. So thank you so much and take care. Have a great evening ahead. Thank you so much.